Hello, everyone. Thank you for joining today's session on your favorite channel, Cancer Reach. Cancer Reach is an initiative by our very own doctor, Dr. Krishnamani, to spread awareness about cancer and to help patients and caregivers to access the right treatment at the right time. September 15th every year is marked globally to shine a light on lymphoma, one of the most common yet often not well understood blood cancer. Hence, today's topic, World Lymphoma Day, straight talk on symptoms, diagnosis, and hope, is drafted with a simple but powerful goal to raise awareness, encourage early detection, and remind patients and families that there is real hope with today's advances in treatment. Joining us today is none other than Dr. Krishnamani, one of the most respected names in oncology. For over a decade, he has been a cornerstone at AOI hospitals here in Hyderabad, where he specializes in solid tumors, blood cancers, and in oncological emergencies. With prestigious international fellowships and leadership roles across India's top cancer centers, he brings both deep clinical expertise and a global outlook to patient care. His work has also shaped cancer care policies, treatment protocols, and research, making a real impact beyond the clinical picture. What patients and families admire most, however, is his compassionate and empathetic approach, which has made him a trusted guide on their cancer journey. We are honored to welcome you today, sir.
Good afternoon. Hello and welcome to Cancer Reach. And Cancer Reach is an initiative to spread awareness about cancer. And as you said today, let's talk a little bit about lymphoma on this World Lymphoma Day.
Sure, sir. So, sir, just to begin with the topic, can you explain in very simple terms what is lymphoma? What kind of a cancer it is?
So, first of all, lymphoma is a cancer. Now, it's a cancer which starts in a lymph node. So, we all have lymph nodes in the body, be it in the neck, be it in the armpit, be it in the groin, in the abdomen. The lymph node, the purpose of a lymph node is it helps in drainage. It helps in drainage of a fluid called lymph. Now, if a cancer develops in a lymph node, it's called a lymphoma. Now, somebody can have a breast cancer and that cancer can spread to the armpit lymph node. That is not a lymphoma. That is breast cancer metastasis or spread to the axillary or armpit lymph node. Somebody can have a oral cancer and have a neck lymph node. That is not a lymphoma. The lymph node will be enlarged. It has cancer, but it is not lymphoma. It is oral cancer spreading to this lymph node. When you have a cancer which develops in a lymph node, that's a lymphoma. Broadly, there are two types: Hodgkin's lymphoma, non-Hodgkin's lymphoma. Broadly, in non-Hodgkin's, there are multiple types. Some are slow growing, like follicular, some are rapidly growing, like Burkitt's lymphoma. Sometimes, unexplainable reasons, you also have lymphoma in the brain. Technically, you don't have a lymph node there. That is called a primary CNS lymphoma. You can have lymphoma in non-lymph node, that is called extranodal lymphoma, like your gastrointestinal tract, like the stomach, like the small intestine. You can have a lymphoma in the bone lymphomas, primary bone lymphomas. So, lymphoma is a primary cancer starting in the lymph node. It doesn't have an origin anywhere else. A spread from another cancer to a lymph node is not lymphoma. Broadly, Hodgkin's and non-Hodgkin's. You can also have extranodal lymphoma, like in the brain, primary CNS lymphoma or primary bone lymphoma. Or also sometimes you can have just water around the lung, which is called primary effusion lymphoma, especially in HIV positive patients.
So, sir, when you talk about lymphoma as a disease, what exactly is happening in the body when a patient has lymphoma?
So, in lymphoma, we use a term called B symptoms, B for Bombay. B symptoms are if they are constitutional symptoms, that is regular symptoms, which can happen in any disease. Fever, prolonged fevers, low grade fevers, night sweats, loss of appetite, and weight loss, significant weight loss. So, In lymphomas, on one side, you can have these B symptoms. So we say whether a lymphoma patient has B symptoms or no. B symptoms means unexplained weight loss, continuous fever, and loss of appetite, these kind of things. Okay. On the other hand, you get symptoms due to the node. If you have a lymphoma in the neck node, the neck node will increase. If you have an armpit node will increase. You'll have pain, you will have swelling. If you have it in the abdomen, you will have pain, you will have swelling, you will have early satiety. We say the patient says, I eat little, my abdomen is swollen. Okay, so these are all the uh, disease specific. If you have primary CNS lymphoma, you will have mood changes. You may have seizures. You may have weakness of one side of the body. You may have severe headache. You may have double vision due to pressure in the brain. So lymphoma symptoms could be B symptoms or symptoms due to the lymph node per se.
So, has it ever happened that maybe a patient has had persistent fever for a longer period of time, or the patient has been very tired and they've come to you for a checkup, thinking that it could be something serious?
People do come like that. See, just because you have fever for 6 days or 4 days or you doesn't mean you have a cancer or a lymphoma. The cancer diagnosis or any cancer diagnosis should be only when symptoms are there for a reasonably long period, maybe 2 3 weeks, when they are unexplained, when you have ruled out all the common causes. Now, if somebody develops a 2 day fever in this weather, you will talk about viral infection. If somebody is having burning in the urine, you're going to talk about urinary tract infection. Somebody is coughing sputum, you're going to talk about pneumonia or a respiratory tract infection. You're not going to think of a lymphoma immediately. So you've ruled out all causes. You've had an extensive workup. Fevers are not or symptoms are not improving. Common diseases, the course of antibiotics or antivirals is also over. Despite that, you are not doing well. Then it means you need more evaluation, which is beyond the scope of a primary physician sometimes.
Sir, how do you diagnose this condition?
I told you the symptoms. Please understand when you so diagnosis is one is based on the symptoms. Two is the investigation part. Like each time on Cancer Reach, I say, like how our teacher used to teach us. There are 3 steps. I will do test to confirm the diagnosis. I will do test to stage the disease. I will do test to support my diagnosis or for the general health of a patient. So how will I first question? What is the test to diagnose or to confirm the diagnosis? Biopsy. So if you see a lymph node clinically or on a scan, looks like a lymphoma, do a biopsy. In lymphoma, generally we do an excision biopsy. Suppose this is a lymph node, we remove the lymph, we ask our surgeon to remove the lymph node completely because in lymphoma, you want the complete lymph node to look at its architecture, we say. You will not cut it. You will not take a small piece that is called a true cut biopsy. In lymphoma, generally you want an excisional biopsy. So an excision biopsy will help me confirm my diagnosis, tell me it is lymphoma. On that, it will tell me whether it is Hodgkin's or non-Hodgkin's. On that, I will do immunohistochemistry to subtype the type of Hodgkin's or non-Hodgkin's. Once that is done, I will do test to stage the disease. Lymphoma, you should also see where all the disease has spread. Generally, PET-CT scan is done or advised. Sometimes you may need a bone marrow. You will take a small quantity of blood from the hip bone to see if the bone marrow is involved. Finally, I will do tests to see the general health of the patient or some additional tests like complete blood picture, kidney function, how is the liver function. You will do HIV, hepatitis C has to be checked because lymphomas are very common in retroviral positive, HIV positive patients. Some lymphomas are seen in hepatitis B, some lymphomas are seen in hepatitis C patients. And the treatments you give in lymphoma, they become, what do you say, the side effect increases because of the treatment. If you have HIV or hepatitis B and you don't treat it, you got it. So suppose somebody has HIV, hepatitis B, you don't know and you're not treated. The virus is growing in your body. At the same time, you're hitting the lymphoma with chemotherapy and immunotherapy. What happens is there can be an acute liver failure because of your treatment. Okay, or the HIV can the viral load can become very high. So all lymphoma patients should have a viral workup, and they should have some additional blood tests like LDH, ESR, etc. For a primary CNS lymphoma, you'll do an MRI brain. For a primary gastric lymphoma, you'll do an endoscopy. For primary intestinal lymphoma, you'll do a colonoscopy. So these are additional tests. Biopsy, PET CT, bone marrow plus or minus, blood test, in the blood test, complete blood picture, kidney, liver, viral markers, LDH. These are the common tests.
So once you are done with diagnosing the disease, what would be the most common treatment which is given for lymphoma patients?
Surgery is not a part of treatment, period. Surgery is only to give you a diagnosis for excision biopsy. Radiation is used in lymphoma in certain circumstances, but the most common treatment used in lymphoma is chemotherapy plus immunotherapy, or it is called chemoimmunotherapy, where I'm talking about non-Hodgkin's lymphoma, where you would use chemotherapy with a drug called rituximab. In lymphoma, there is a receptor or an antigen which is called CD20. This rituximab goes and binds and blocks the CD20. So the cell dies. So on chemotherapy, if you add this rituximab injection, the results are much better. Chances of survival are much better. Risk of recurrence is very, very low. Risk of death is very, very low. Okay. So in non-Hodgkin's lymphoma, you give chemo plus immunotherapy. In Hodgkin's lymphoma, you give generally chemotherapy. Now people have started using upfront also immunotherapy or drugs called ADC. We have discussed ADC previous classes. A drug by name brentuximab. But still in Hodgkin's lymphoma, generally ABVD is the chemotherapy of choice. It is given every 2 weeks for 4 to 6 cycles. In between, you will do PET scans in both the lymphomas. If the disease is coming down, you will give additional few cycles and then you will stop. And then it will keep them under regular follow-up. So bottom line, lymphoma is highly curable, usually treated with chemo, plus or minus immunotherapy. Non-Hodgkin's, we give a drug called rituximab. That's a wonder drug. And after 3 or 4 cycles, scan. And in lymphomas, we have reached a point where we are de-escalating treatment also. If somebody has got an excellent response, we reduce the treatment so that they don't develop treatment-related side effects in the future.
Would it be safe to say that patients with lymphoma are having a good prognosis today based on
Excellent
the options
prognosis.
which are available? So both the types, Hodgkin's and non-Hodgkin's, all patients of lymphoma have a good prognosis today.
Yes. Yes.
Okay. So, what about bone marrow transplant for lymphoma? Since it is a blood cancer, that could also be an option.
In relapsed lymphoma or refractory, relapse means disease comes back. Refractory means your initial chemo itself has not worked. The disease has not listened to your chemo. Refractory. Relapse means it has listened and come back. In these two cases, in these two scenarios, you do something called chemotherapy first, which is called salvage chemotherapy. That is, you give another round of new chemotherapy, which is called salvage or second line chemotherapy, and take them up for transplant. Transplant means autologous transplant. Their own cells are taken to kill the disease. So transplant has a role. It is usually autologous. Allogenic is also done. Autologous transplant is in relapsed refractory lymphoma after salvage chemotherapy. You will give 2 cycles of chemo. The increased disease or the relapsed disease, if it comes down, then you will take the patient for transplant. But usually you don't do transplant in patients more than 70, 75 years.
And so, what does recovery look like for these patients? Can they go on with living their lives normally, like before the diagnosis of the disease?
Correct. They will. So the only risk is again post-transplant recurrence of the disease. In autologous transplant is very simple, unlike allogenic. So in autologous, it is only your 20-day hospital stay, 25-day hospital stay, whatever. At that time, your WBC counts, infection, your platelet counts, and all that we have to worry. Otherwise, those patients do well after that, and they are under periodic follow-up to check if the disease has come back.
So, what message can we give to the families or the caretakers of such lymphoma patients regarding the long-term care or the follow-up care for lymphoma patients?
Lymphoma patients, attenders should understand that, see, there are a lot of, see, it's a good disease generally, highly curable, but some cases are not curable at all. If you have an extensive stage from day one, if you have bulky disease, that is, tumor is very large in size, if your tumor has not responded to the initial chemo, refractory lymphoma, if it is a relapsed lymphoma, if it has not responded to your salvage regimens, there are some scores. That is, if we call that as IPI score. If your IPI score is high, that is, you have disease in the testis or you have disease in the extranodal areas. Okay, your general condition is low. Then those are the patients who are not going to do well. But still, in lymphoma, we have to aim for cure. But those who have advanced disease, those who have poor general condition, those who have high IPA score, those who have extranodal disease, those who are primary refractory, they are all the patients who are not going to do well. Then maybe what you have to do is give some form of chemotherapy or immunotherapy or brentuximab or drugs like lenalidomide and then take them further. Now, CAR T cell therapy has come, which is a new kid in the block. CAR T cell therapy is being done, and CAR T cell therapy, especially for non-Hodgkin lymphomas, is first line when you relapse. So it is there in India. Our colleagues are doing it. So what we should understand is, even if you have a relapsed lymphoma, there are options.
So, what about the financial part related to the treatment for the lymphoma patients? Is it on is it more on the expensive side or?
No, see, Hodgkin's lymphoma, the ABVD which you are using, even in a corporate hospital, one cycle of ABVD should not cost you more than 25,000. It is covered under all the health schemes, including Ayushman Bharat or Arogyashri. For non-Hodgkin's lymphoma, your R-CHOP, which we use, it is covered under Arogyashri if you are a poor patient. Otherwise, R-CHOP per se, if you come, it should cost you somewhere close to 60, 70,000 per cycle for 6 cycles. So those under insurance, those who have some kind of corporate funding, okay, for them it is not a problem. The beauty is for the really socially economically backward, it is covered free under Arogyashri. They will get even rituximab now, which is a, as I told you, a very important drug and is a wonder drug. Now, when it comes to relapsed lymphomas, yes, it's expensive because you are thinking about transplant. An autologous transplant, even in a government hospital, can cost between 3 to 5 lakhs, depending on the complications a patient can have. Immunotherapy in India today can cost anywhere between 10 to 11 lakhs for a whole year of treatment. It is much cheaper than the West. In the West, one cycle cost 8 lakhs. In India, maybe 16 or 17, not maybe, 17 cycles cost you 11 lakhs. There, one cycle cost you 6 to 8 lakhs, the same drug. But still, uh, you cannot compare India with the West purely because our people's GDP per capita is less. So that 10, 11 lakhs is also a big thing for our people, and it is not covered under the health schemes and all that because it comes under the relapsed setting. So for the initial treatment, it should never be a problem. But if things go out of hand and get relapsed, then yes, expenses will shoot up. Much cheaper than the West. Many people help. There will be a lot of donations available. There will be support groups, but some amount of financial burden will definitely be there.
So, what about the lifestyle changes for the lymphoma patients? What would you advise them?
Nothing, basically. We all asked them to eat a balanced diet. In the initial days, if you have a lymphoma, large lymphoma, we asked them to avoid fruits, fruit juices, and coconut water because we want to avoid high potassium in the blood. But otherwise, have a balanced diet, green vegetables, home food, less spice, less oil, your breathing exercises, yoga, walking, whatever you're doing, you can do all that. You should do all that. Be active, listen to music, read, carry on with your daily activities.
So, what would be like one golden message that you want to give to your patients and to their family members on this World Lymphoma Day awareness program?
Lymphoma is treatable, no doubt. It is curable. So leave no stone unturned to treat a lymphoma patient. Come on time, take your treatment on schedule. Um, these patients, due to chemotherapy, can develop infections like neutropenia, etc., fall in WBC count. Watch out for those signs. Reach out to your doctor and be on time and take your treatment on schedule is extremely important because that dose delivery of the drug will help you in controlling the disease and eventually curing it. So don't lose hope.
Sir, can you just tell us about the second opinion campaign which you are running?
So we have a second opinion campaign on Cancer Reach. People can reach out to us. It's free, and the aim here is wherever you are in the country, you have a cancer patient, you can reach out. We will try to give you an opinion as best as we can, knowing that the patient is obviously not with us, so that at least you have some informed, so that you can do some informed decision making based on the reports. What little we can, we would like to guide you. We would be happy to guide you.
Thank you for this awareness program on lymphoma, sir. And we hope to meet you again next Friday with another interesting topic.
Sure. Thank you so
Thank you,
much.
sir.